Right, great. Thank you, everyone, for joining us this morning. This is one of our special grand rounds. This is sponsored today by the endowed Laura Mann Integrative Healthcare Lecture Series. Laura Mann was a nurse midwife, and when she was diagnosed with stage 4 breast cancer, she integrated Western medicine with complementary and alternative medical therapies. And despite her untimely death, her vision, Laura's vision, is alive through the endowed Laura Mann Integrative Healthcare Lecture Series. This series brings distinguished leaders to the University of Vermont to share best practices, research, and innovations in integrative health and medicine. And the series is hosted by the UVM Integrative Health, a joint endeavor of the UVM College of Nursing and Health Sciences, the Larner College of Medicine, and UVM Medical Center. Today, we're welcoming Melinda Ring. Melinda Ring, Dr. Ring, is the Executive Director of the Osher Center for Integrative Medicine at Northwestern University. She is also the Doctors Pat and Carl Greer Distinguished Physician in Integrative Medicine, Clinical Associate Professor of Medicine and Medical Social Sciences at Northwestern University, Feinberg School of Medicine. And Dr. Ring completed her medical degree in internal medicine residency at University of Chicago and completed her fellowship in integrative medicine at University of Arizona with Dr. Andrew Weil. I never know.
Weil, yeah.
I think I'll stop it there. There's a lot more to go, but I think that I would rather listen to Dr. Ring speak than myself and hear all the things that she has to share with us. So welcome, Dr. Ring.
Thank you. All right, so my goal today, thank you for having me here. My goal today is to describe the current state of gender health disparities for those who are involved in women's healthcare, which I think is a lot of our audience today, how they relate to restrictive gender norms and inequities, and then their intersection with other social inequalities like race, ethnicity, and socioeconomic status. On the optimistic side, I'm going to share some emerging actions to recognize and transform healthcare culture around sex and gender inequalities. I believe every person here today can be a catalyst for change to enable all people to live to their full human potential by upholding human rights and improving health and well-being for all. I don't have any conflicts of interest other than that I'm a woman. So when a woman comes into our office to share her health concerns and history, we're not just hearing some outcome that we could easily predict from her genetic code. We're hearing the culmination of her whole world, the impact of her human interactions from her family of origin to the community where she spends her days, and not just the diet she follows, but the groceries she has access to in her neighborhood, the quality of the education she's been given, and the goals that she's been encouraged or not to reach, the support she has in raising her kids and taking care of her home, biases and critiques that shaped her ability to find a well-paying job, and any trauma she's experienced and whether she feels worthy of taking care of herself. Now, in integrative medicine, it inherently acknowledges the totality of a woman's experiences in shaping her health and well-being. And we realize prescription needs to include not just medications, but things like nutrition and green space and connection. And in sharing those recommendations, we also need to appreciate the social determinants of health that impact whether a woman can find those anti-inflammatory vegetables in her neighborhood, has someone to watch her kids so she can practice a 10-minute breathing exercise, and is in a safe setting where she can go for a walk in nature. Today, I'd like to focus on the intersection of those social determinants with forces that have come sharply into public awareness in the past several years, like bias, oppression, and discrimination, and how they impact this woman's ability to live a healthy and meaningful life, and what we as a community of healers can do to address them. There is sadly no positive examples in women's health disparities, violence, and oppression to share. I'm going to start by providing a framework for thinking about women's health, sex, and gender, and then we're going to dive into examples of gender health disparities and traumas that stem from interactions with the healthcare system. The majority of the existing data does come from studies of physicians, but is certainly relevant to all professions within healthcare. And then, on an optimistic note, we'll close with some promising efforts to address inequity, discrimination, and oppression. Traditionally, medical care has been dominated by men. You can see that by looking at auditorium walls and hallways of esteemed academic centers and the monotony of the subjects. This historic lack of female representation in the medical field meant that men and women were treated with this one-size-fits-all approach for a lot of time. And it wasn't until 1849 that Elizabeth Blackwell became our country's first female physician. Blackwell had to battle sexism and prejudice, but she persevered and she founded a small clinic that eventually grew into the New York Infirmary for Women and Children and opened the first women's medical college in 1868. However, the concept of women's health didn't emerge until the 1960s and 70s as part of the larger women's health movement. As women fought for equal rights, equal pay, and access to higher education, they were also fighting for equal health care. Some of you may remember this book, maybe not the young residents, but the publishing of the best-selling Our Bodies, Ourselves, a book written by women for women, revolutionized views about the female body and sexuality. The Boston Women's Health Collective states in the preface, "We have decided that health can no longer be defined by an elite group of white upper middle class men. It must be defined by us, the women who need the most health care, in a way that meets the needs of all our sisters and brothers, poor, Black, brown, red, yellow, and pink." Women began demanding better services to meet their needs throughout their lifespans, from childhood and adolescence through perinatal care and past menopause. So originally, the concept of women's health was synonymous with issues related to childbearing, breast health, and menopause, but it's evolved over the past decade to include much more than reproductive issues, as in this definition from the National Academy on Women's Health Medical Education, and it focuses now on all aspects of health prevention and well-being. It's important to note that just like the Black Lives Matter movement is a fight for freedom, liberation, and justice that impacts all humans, the calling out of women's health is a fight for personalized care that eliminates rigid norms for all. By acknowledging the role of biologic differences, gender, social determinants, it's moving healthcare towards one that sees every person's health as uniquely influenced by complex interactions between biology, behavior, and the environment. So turning towards disparities in relation to women's health, the discussion of sex and gender health equity is complicated because gender can be interpreted in different ways. For example, sometimes gender and sex are used interchangeably, but other times gender is conceived as someone's identity, so a deeply held personal self, a sense of oneself as male, female, transgender, non-binary, fluid, genderqueer, any of the other gender identities. For today, we're defining sex disparities as distinctions in health that are based on biology, like our chromosomes or hormones, and then defining gender disparities as differences that stem from the socio-structural construct that assigns power, resources, roles, and status on the basis of gender norms, and whether someone's perceived as being male masculine or female feminine. Of course, ultimately, sex and gender are entangled, and they need to be viewed as interconnected to fully understand the complexity and nuances of health outcomes. Investigation into the underlying biologic basis of male versus female differences was largely neglected until a report released by the Institute of Medicine in 2001. It was called Exploring the Biologic Contributions to Human Health. Does Sex Matter? And of course, the answer is a resounding yes. As some examples, we know sex contributes to biologic and physiologic differences that influence disease onset, risk factors, routes of entry, prevalence, severity, comorbidities, and signs and symptoms. sex influences drug pharmacodynamics, how drugs are absorbed, distributed, metabolized, and eliminated. If you look at reviews from the adverse events reporting system, women experience more adverse events than men, and the adverse events are more serious in women. Among new drug applications, when they include a drug analysis, up to a 40% difference in pharmacokinetics is seen between men and women. But as many of you know, there's really no differential dosing recommendations made for those drugs despite the difference. And lastly, sex differences in physiology are influenced not only by genetic sex, but also by the hormonal environment created by the production of sex steroid hormones. Like we know, hormonal shifts around menses, pregnancy, and menopause are linked to depression and mood disturbances. And gender norms also impact health inequities and outcomes because both a woman may herself make decisions about how she interfaces with healthcare based on those gender norms. And then there are biases within the healthcare field. And we'll talk about that. Let's use cardiac disease as a good example. So we'll put them together and look at how sex and gender influence health. So cardiac death continues to be the leading cause of death among women of all ages, leading to about 1 death per minute in the USA. When we look at sex-related differences, some examples are that women are twice as likely to experience microvascular angina as men, which is associated with an increase in acute coronary syndrome events and heart failure with preserved EF. Up to 30% of women have no culprit coronary lesion on angiogram, and that can lead to missed or delayed diagnoses. And then there are certain cardiovascular diseases with a strong female predominance, like spontaneous coronary artery dissection, long QT syndrome, and others. And going to the hormonal milieu, we know from experimental and clinical studies that estrogen and testosterone have very different effects on plaque development, atherothrombosis, coagulation, vascular injury, and healing. The estrogen decline in menopause has been associated with changes in body fat distribution, endothelial dysfunction, vascular inflammation, sympathetic tone, and insulin resistance. So these are some of the sex-related differences. What about gender-related differences? So looking at, again, acute coronary syndrome between men and women, we see that women have a longer time from when they start to have symptoms to when they present. This is thought to be partly related to them being primary caretakers. They may delay prevention and treatment. And many women report atypical symptoms like nausea or vomiting, shortness of breath, dizziness, or no symptoms at all. Women are less likely to get diagnostic testing like EKG or troponins. And they're also prescribed less often secondary prevention therapy or coronary revascularization. When you add that all together, women with ST elevation, MI, have higher mortality rates than men. So while education of patients and providers may reduce sex differences in outcomes, eliminating gender-based disparities takes understanding some of the underlying factors. There was a well-known study, it was published over a decade ago, actually 2 decades ago now. Investigators devised a clever experiment to address this problem. This was done at a conference, and there were actors that were posing as patients with chest pain, and primary care physicians sat with them and had to give recommendations. What was found was that primary care physicians were less likely to refer women for cardiac catheterization than men. The patients were carefully designed to be identical in age, risk factors, and symptoms, and they followed a script standardizing patient communication, which suggests that physician bias based on gender accounted for the different treatment recommendations. Another issue is lack of awareness by women of the symptoms and risk of heart disease. This was just published data that showed that awareness that heart disease is the leading cause of death among women actually declined from 2009 to 2019, particularly among Hispanic and non-Hispanic Black women and in younger women. And these results suggest we have this urgent need to escalate efforts to educate women through awareness campaigns, cardiovascular screening, and counseling. Another issue is, you can see this in the red there, the insufficient number of women who are enrolled in cardiovascular research studies. Before 1993, many large cardiovascular trials studied only men. And then concerns about gender equity in research led to 2 federal mandates for the inclusion of women. There was the NIH Revitalization Act of 1993. It required that all clinical studies that were funded by the NIH include women as subjects. And then there was the FDA's guideline for the study and evaluation of gender differences in the clinical evaluation of drugs, calling for the examination of sex differences in pharmaceutical trials. This was a good seminal advancement in women's health research, but we can see here again by the gray bars that women still represent less than 1/3 of subjects in cardiovascular clinical trials. And the last factor I want to mention is the paucity of women in the field of cardiovascular disease. While internal medicine trainees are evenly split by sex, and I think family medicine may be as well, less than 20% of cardiology and less than 9% of interventional cardiology fellowship trainees are women. Within the subspecialty of interventional cardiology, the gender disparity is greater. So a study that was performed by in the US by the Women in Innovations group found that women account for only 4.5% of practicing interventional cardiologists and perform less than 3% of angioplasties. And as the late RGB said, women belong in all places where decisions are being made, and that most definitely includes the need for women in all aspects of healthcare. So we just looked at the disparities between women and men and some of the issues. Another problem is disparities within different groups of women. So I'm going to turn towards this now. So what is Healthy People? You've probably seen this. Healthy People is a program. It's managed by the Office of Disease Prevention and Health Promotion at the US HHS. Every decade, it provides science-based 10-year national objectives for improving the health of all Americans, establishing benchmarks, and then it monitors progress over time. A major goal of the Healthy People 2020 was achieving health equity, eliminating disparities, improving the health of all US population groups. And, again, we know that there are many factors that contribute to an individual's ability to achieve good health. So let's look at some of the disparities and how we did at the looking back in 2020. By family income, the disparity in the percent of women receiving a pap smear within the past 3 years actually worsened. If a woman was less than 100% the poverty threshold, which is currently a single person family income of $12,760 per year, less than 70% received recommended screening for cervical cancer. Whereas for women who were 600% plus the poverty threshold, almost 90% were screened for cervical cancer. By resident, women who live in metropolitan areas with presumably greater access to healthcare were less likely to die from cervical cancer. Almost 70% of women who had private insurance received counseling about mammograms compared to 33% of uninsured women. Only 63% of women who attained less than a high school education had breast cancer screening, whereas over 80% of those with an advanced degree had a mammogram. Black women were significantly more likely to present with late-stage breast cancer compared with other race and ethnic groups. And similar trends in death related to breast cancer. There are, I could keep going, innumerable examples of persistent health disparities based on these societal factors, despite these admirable goals of the Healthy People Project. Here's some other ones. African-American women account for 58% of new HIV diagnoses out of all women. Latino women are the most likely to be uninsured. Asian American girls have the highest rate of depressive symptoms. American Indian, Alaska Native women have the highest rates of intimate partner violence. And as you may have seen in the news, the pandemic's just widened those gaps. As one example, women of color, we already know they may experience increased risk of maternal mortality and morbidity, as well as COVID-19 infection and death. There's been reports of alarmingly high rates of COVID-19 among Black and Latino people, and that compounds already what was an existing maternal health crisis. So Hispanic and non-Hispanic Black women are more likely to be affected by COVID-19 during pregnancy. Again, even before the pandemic, Black women were 3 to 4 times more likely to die from pregnancy-related complications. And then you add on, and we know pregnant women with COVID-19 are more likely than non-pregnant women to be hospitalized, admitted to the ICU, to receive mechanical ventilation, and to have a C-section. So ultimately, to address health inequity, we need to address social inequities as proclaimed in the Robert Wood Johnson Foundation's Community in Action report. A report from the National Academy of Sciences, Engineering, and Medicine calls for leaders across sectors to make health equity a priority for the nation. It states, health inequities are the result of more than individual choice or random occurrence. They are the result of poverty, structural racism, and discrimination. Health systems are just one cog in the wheel of the health inequity issue, but the role they play in the problem is a big one. So I'm going to shift now to another sobering story. That's the result of, that of trauma that women experience as a result of interacting with the very healthcare system that should be there to serve and uphold them. And today I'm going to focus on obstetric violence. The term obstetric violence was first defined and legally adopted by Venezuela in 2006. It defines obstetric violence as the appropriation of the female body and reproductive processes by health professionals, which is expressed as dehumanized treatment and abuse of medication, and to convert the natural processes into pathologic ones, bringing with it a loss of autonomy and the ability to decide freely about their bodies and sexuality, negatively impacting the quality of life of women. While much of the discourse in the mainstream media and social media around the issue is centered around assault, harassment, and disrespect during actual childbirth, like forced C-sections and episiotomies, obstetric violence can occur even during the perinatal period. It can include things like denial of treatment, verbal humiliations, invasive practices, a lack of privacy during vaginal exams, and of course, sexual assault. And although it was first described in Latin America in the 2000s, it's really a global issue. Just some examples. In Nigeria, 98% of women report at least one form of disrespectful and abusive care during their last childbirth. In India, physical abuse ranged from 3.7 to 40%, verbal abuse from 17 to 55%, with a discrepancy between women of low SES compared to high SES status. And in Italy, one of the more developed countries, 21% of women consider themselves victims of obstetric violence, and 6% stated that they would not have any more children specifically because of the treatment that they received. And while the term obstetric violence appears nowhere in US law, many women in this country are victims of this human rights violation. More than half of birth workers, which include things like, specialties like doulas and childbirth educators, labor and delivery nurses, reported they witnessed a physician engage in a procedure explicitly against a woman's will. Listening to Mothers 3 survey found that 25% of new mothers who had labor that was induced or C-sections felt pressured to do so. During the hashtag Break the Silence social media campaign that was led by a consumer advocate group called Improving Birth, Hundreds of women shared their experiences of bullying, coercion, and unconsented procedures like episiotomies and vaginal exams during birth. And perhaps in one of the most heinous examples of this, in September, the news erupted with the whistleblower allegation that a doctor that she called the uterus collector was performing an alarming number of hysterectomies on immigrant women that were detained by the Immigration and Customs Enforcement. And this brings to mind the history of mass sterilization of people of color and incarcerated people. In addition to the immediate physical harm, the emotional impact of mistreatment during childbirth can create lasting injuries. Birth trauma, we know, impairs postpartum well-being that may require counseling or other treatment and interfere with transition to motherhood. Experts conclude that up to 9% of new mothers satisfy clinical criteria for PTSD. The physical and emotional harm of mistreatment also can lead to just overall poor health and making it more difficult to care for their children, the babies, and whether it's because they have longer recovery from unnecessary surgery or diminished emotional health like postpartum depression, anxiety, mistreatment during childbirth can have long-lasting effects on adjustment for both women and babies. As awareness has grown, NGOs and international human rights bodies have mobilized to address abuse during childbirth. While many countries, like in Latin America, have enacted strict laws against it, others, including the US, lag behind. This is a statement from the World Health Organization. Every woman has the right to the highest attainable standard of health, which includes the right to dignified, respectful health care. And finally, let's explore the existence of trauma and discrimination for the women who serve within the healthcare workforce. As the Me Too movement raised awareness of sexual harassment in business and in Hollywood, it prompted women in healthcare to confront health systems where workers are often discouraged from making waves and where hierarchies are deeply ingrained. So sexual harassment can be characterized as gender-based harassment, like use of suggestive language or crude jokes or sexist comments or sharing sexist imagery, unwanted sexual attention, which could be verbal or physical, and sexual coercion, whereby advancing in your career is contingent upon favors. So as early as 1998, sexual harassment was called out for its prevalence in medicine, but didn't really get much attention at that point. The 2018 report by the National Academy of Sciences, Engineering, and Medicine was a pivotal account and talked about the pervasiveness of harassment in academia, describing it as common, especially in medicine. This was published earlier this year, and it reports on the faculty at the University of Michigan Medical School who reported sexual harassment. They administered a 20-minute online survey to all faculty who had been working there at least 1 year. And 82.5% of women and 65.1% of men reported at least one incident of sexual harassment from insiders, meaning staff, faculty, or students in the past year. And 64.4% and 44.4% of men respectively reported harassment from patients or patient families. And when they correlated these, there were people who had an increased experience of harassment was associated with lower mental health, job satisfaction, and sense of safety at work, not surprisingly, as well as an increased intention to leave the workplace. Similar rates were reported in a tertiary referral center in Berlin. 76% of female and 62% of male physicians reported some form of misconduct while performing their work. And in this study, those that had reported more sexual harassment were in departments where there was a strong hierarchy, highlighting here the importance of organizational culture and whether there's a permissiveness of unacceptable behavior. perhaps most disturbing and relevant to some of the visitors today, a significant amount of literature indicates that medical students, trainees, and other healthcare learners are at risk for sexual harassment. These members of our healthcare system are particularly vulnerable because there's just inherently this unequal power dynamic between learners and their evaluators, or between learners and their patient. In the 2018 AAMC graduate questionnaire, 5% of graduating US medical students reported unwanted sexual advances, and 16.5% were subjected to offensive sexual remarks. And for residents, this was a survey of 34 residency programs across 14 academic medical centers, reporting rates of sexual harassment that ranged from 2 to 12%. Surgical specialties were at the high end, peds was at the low end. And again, trainees who reported sexual harassment also reported lower vitality and higher ethical and moral distress. In the wake of the Me Too movement, the Mayo Clinic saw a surge in reported allegations of sexual harassment. More people felt empowered to come forward with complaints. And this was a review that they published again earlier this year. And of the 153 allegations from 2017 to 19, a male was accused in 82%, female in 18%. In 46% of cases, the two individuals were peers, while 28% there was a leadership subordinate relationship. 88% of the cases were substantiated, leading to corrective action that varied from coaching to termination, depending on the nature and severity of the misconduct. And beyond sexual harassment, women in medicine also experience discrimination that affects everything from pay disparity to promotions to publications. In a survey of emergency medicine faculty across 6 US programs, women were more likely than men to report gender-based discriminatory treatment. And in another University of Michigan survey of faculty who had received K awards, women were more likely than men to report perceptions in the environment and personal experience of gender bias in their careers. Underlying gender inequality and discrimination in healthcare is the blatant fact that most healthcare is delivered by women but led by men. And women make up 70% of health and social care workers, but in most countries, there's a higher proportion of male physicians, shown here in red, while the nursing and midwifery workforces are much more highly represented by women. And whether we're looking at Fortune 500 healthcare CEOs or ministries of health, men hold more senior roles in healthcare. So again, what do we need to do here? There are 4 key areas that need to be addressed through transformative policies to achieve gender and equity in the global health workforce. This was from the WHO. Occupational segregation, such as women being clustered into lower status, lower paid jobs, the gender gaps in leadership, gender pay gaps, which at 26% between men and women is higher than in other workplace sectors. And then what is termed decent work, wherein women in the health workforce face bias, discrimination, and sexual harassment. So let's talk now about solutions. It's going to require drastic change from within and really seismic shifts at the macro level of oppression and discrimination. It may seem an overwhelming task, but there's already substantial steps being taken around the globe that give me hope that we'll see change within our lifetime. And to end on a more uplifting note, I'll share these with you as some tools that you may want to access and share so that you can be part of the needed change. In 2019, the Lancet, one of the oldest, most prestigious medical journal, published its landmark hashtag Lancet Women Report. It dedicated an entire issue to providing peer-reviewed evidence for the institutional and systemic barriers impacting women's experience and advancement in science, medicine, and global health. Topics in this issue ranged from recognizing implicit bias to best practices to address gender inequality. The issue demonstrates that gender inequality continues to exist in the scientific field, especially for women in marginalized groups, and it offers approaches on how to tackle this imbalance. This was a great issue. If it's an area of interest, I recommend reading the whole thing. The hashtag Lancet Women is now an ongoing initiative, and they are doing commissions in cardiovascular disease, gender-based maltreatment of young people, cancer, migration, and reproductive rights. So again, I highly recommend exploration of these high-quality articles. And as another sign of progress, for the first time ever, the majority of US medical students are women. That's another milestone in the gradual diversification of those studying to become America's next generation of physicians. And they need to be mentored to enter all fields and whatever field makes the most sense and that they're interested in. There's also new curricula available to increase awareness of equity issues, such as a module from ACOG, and a multi-part course from the NIH Office of Research on Women's Health. It's called Bench to Bedside, Integrating Sex and Gender to Improve Human Health. There are 6 free modules available. It looks at sex and gender differences in immunology, cardiovascular disease, pulmonary disease, neurology, endocrinology, and mental health disorders to help identify gaps in research methodologies, differences in pathophysiology and disease process, and steps required to improve the diagnosis and treatment in women. In terms of national initiatives, Healthy People 2030 was released in August. In addition to continued emphasis on the elimination of health disparities, it pulls out the promotion of women's health and well-being as a major goal. We'll see how successful their initiatives are. I felt like the results of the 2020 Healthy People Initiative were underwhelming, but I'll try to stay optimistic. There are also multi-year programs in progress across the globe from organizations like the UN and WHO. And while those major sustainable development goals are important objectives that are going to require cooperation among governments, international organizations, and world leaders, there are steps we can all take as individuals to make an impact. As the UN site shares, every human on Earth is a part of the solution. For those here today, and particularly, my colleagues in the integrative health realm, your work at the bedside, bench, and in communities are all critical components to achieve equity and the quality of healthcare received by women. And I think this is true of family medicine and integrative medicine. There's a focus on patient-centeredness, meaningful relationships with the community, attention to barriers of care, strategies tailored to the individual, and innovative research. These are all steps that help the individual patient in front of us and ultimately may culminate in health system reform. So to close with another RGB quote, if you want to be a true professional, you will do something outside yourself, something to repair tears in your community, something to make life a little better for people less fortunate than you. That's what I think a meaningful life is, living not for oneself, but for one's community. Thank you. And I'm happy to take any questions or comments.
I haven't seen any questions come up in the chat yet, Dr. Ring, but
Okay.
I think maybe we're all a little somber.
Yeah. It is a somber topic, but I think awareness is one of the most important things we can have in this area. Just attending to it, and of course, again, it's not just true about women and men, it's true about every individual patient that sits in front of us. I think burnout in medicine and in the healthcare field is a huge issue that leads us to rush through and not attend, not be open and willing to to hear the patients and to hear their needs, and that's so healing the healthcare force is part of what we need to be doing as well. I see a comment about nurses. It says nurses also experience bias and disrespect in healthcare. How can MDs and RNs work together to improve the culture and workplace environment? I mean, I'm happy to have other people jump in, but I think many institutions I'm a believer in medical education and training future generations so that we see change at the start. And so I think there is such a big movement towards interprofessional education where doctors and nurses and dietitians and social workers are all training together to learn to respect each other. Unfortunately, I think that what many trainees see is the kind of behavior that then they think is acceptable and appropriate, and maybe subconsciously start to emulate. So ultimately, I'm happy to hear what others think, but I agree that it's kind of an across the board issue. Medicine is so traditionally hierarchical, and I also want to say that in this talk, it is not male physicians who are the problem in many cases. For example, the obstetric violence cases, many of the OBs who were perpetrators of obstetric violence are women, and in fact, in some cases, female bosses can be harsher than to their subordinates than male, and so I don't think that this is a critique of male physicians or male health professionals. It's really something that we all need to be aware of.
And as you say that, I'm thinking about, though, that inequity in who decides what happens in healthcare versus who provides the healthcare. And when you have a very male dominant group who set protocols and agendas and decide what the algorithm is for the care and who's in power in each of those steps, you don't have to be male or female to be still perpetrating the violence. If, say, the protocol for a woman in labor is if she hasn't got a group B strep result back, she has to have an IV. And that was decided by someone else along the way, even though this person might have a different birth plan. But they have to be very strong to object to someone just sticking an IV in them, which they can do. They can refuse things like that. But that choice to make a decision at that point may have been made by those men in power way many steps back. And then this RN, who's a female and patient-centered, is telling her this is what she has to do.
Right. Yeah. And I think it's very hard for a woman as a patient, particularly in the midst of, a situation to go against her provider and speak up for herself. I think most tend to maybe feel it internally, but not feel able to voice it. Yeah, the idea, what you're describing it of there, that discrepancy. I don't know what it's like at Vermont. At Northwestern, in the medical school, there's actually quite a few female deans, although not the dean. Within the hospital setting, if you look in the C-suite, it is almost all men. And so, yes, I think part of what I talk about doing with our fellows is, we need to nurture more leaders. Of course, that's meant too, but it's sort of nurturing the right type of leader. And even if you're not in a leadership role, if you're on a committee where you can voice concerns about things, or being willing to bring up things that you see, like maybe we need to change this protocol if it seems like it's not the right protocol. I agree with you.
Are you able to see some of the other questions in the chat, or I can just read them out to you if you would like me to?
Sure. No, I see them. You mentioned some metrics among gender health outcome inequity that have actually worsened in recent years. Yeah, that was from the Healthy People 2020. Is there data on why, or hypotheses you have, like specific events, funding changes, organizational changes, income inequality worsening? I don't know. I mean, that's a big societal question. I don't want to get too political, but I think that certain thing that the environment that we've had recently, the political environment, has been one that emphasizes discrimination and oppression. And I don't think that's been good for minorities or those in at-risk communities. What we're seeing in COVID, so in a crisis type situation, we see widening of the disparities, both among social, societal groups, but then also even within the healthcare industry, where when a child, for example, now can't go to school and is virtual, it is oftentimes the woman who sacrifices her career or her other things to stay home with the child. And so I think, we're seeing a widening, unfortunately, in the pandemic, similarly with what I described about the disparity in Black and Hispanic women, and all Blacks, Hispanics having a higher rate of COVID overall. I don't know. I'm happy to have other people jump in with ideas or hypotheses, but I would personally say, again, with this idea of leadership and setting the tone, that I don't think that our leadership in recent years has been one that embraced raising people up. What about the role of health insurance limiting the available resources, access for patients, practitioners, et cetera? In the integrative medicine realm, that is a very big issue, because I know, most integrative services are not covered by, for example, Medicaid. I'm not sure if that's what you have in Vermont, Medicaid, Medicare, and commercial insurance sometimes will cover things like acupuncture or massage. But even, I think programs like what's happening at Vermont, and Kara, I don't know if you want to describe that at all, with the pain initiative for some of the learners on the group. But I think work that's being done to make more services more widely available, that's the kind of work that needs to be done. Kara, do you want to comment at all on this?
I think most people know about the comprehensive pain program, which is a bundled service. So part of the care, they get a group medical visit at our clinic. And in addition, they have access to yoga and acupuncture and massage. And it's a pilot that we're doing with Blue Cross Blue Shield to cover all of those services.
Right. So, Vermont, that program is really one of the examples of a leading initiative to try to change the way access happens, and hopefully is able to have a domino effect to make it happen across the country. what are some of the success stories you've seen in balancing career and family in the healthcare profession, since this is one area where roles contribute to disparity? Again, I'm happy to have other people jump in with this. I think that's, what would I say, a success story. I think this is a difficult question. As much I remember when I was a third year medical student, and I was in my very first rotation, and I was scrubbed into the OR, and I was very excited. I had the big role of suctioning, and I was loving it. I'm like, oh, maybe I want to be an orthopedic surgeon. I think like all med students go through this as they're going through, but I was like, this is so exciting. And then, so I'm in the surgery sectioning, and then this little guy comes in, and he grabs the suctioning tube from me. And I grab it back and I say, I got it. And then he leaves a few minutes later, and then the fellows tell me, that was the chief of orthopedics. And luckily he took this behavior as being enthusiastic and assertive, not as being disrespectful, and we had a good relationship. And so I was talking to him about orthopedics, and he said, well, you could do it, you have the whatever the skills or whatever, you could do it, but I wouldn't recommend it for you, and I wouldn't recommend it for my daughter. And and so hearing that again as a student kind of changed my trajectory of what I thought was the right thing to do. And the reality is I did choose a path that I thought had a better work-life balance for me personally. But I think though that current generations that's not unique to women. I feel like I see that with our male trainees also, that pretty much across the board, people are looking for better work-life balance. And there's more give and take and more sharing of responsibility, both at home and in the workplace. And so in the medical field, I guess I see that as a promise for the upcoming generations that may not be there for those who are older and have been in the field for longer. I don't know if any others who are faculty have comments on what it's been like. Whitney, I don't know if you have any thoughts on that idea of work-life balance and how it impacts career.
I think a lot of us in family medicine are here because of our curiosity about all sorts of medicine, as well as the perception of a work-life balance, the ability to have a lot of colleagues share call, to have a lot of people to bounce your ideas off of, a lot of collegiality within this profession. So I feel like we're in a unique and positive situation. And in our residency program, I feel like we have a lot of people who are very attuned to some of the topics you've talked about. We've had, I've worked side by side with one of our OB providers as she talks to students about trauma and how to use non-traumatizing talk as you're doing something like a pap smear, how to depersonalize it, and make it less threatening. And that's with our third year learners. And I feel like here we're doing a lot of good things, but we've recently recognized, like with Black Lives Matter, we needed to do a lot more. And I think this is an eye-opening kind of topic. And we've kind of created some infrastructure for dealing with diversity and inclusion and inequities that I think will help propel us toward more success. I don't know, anyone else, any ideas? Dr. McRae, maybe?
Thanks, Whitney. Yeah, on the work-life balance issue, and also in gender inequity in healthcare in general. You know, I'm the first female professor in the department, and I'm really proud of that accomplishment. And I think I really owe it to, as Whitney alluded to, our team, and a lot of hard work, but also a lot of support and mentorship, and a lot of mentorship from really wonderful female mentors in healthcare, not necessarily just in different stages of my career, and also from different departments too. And so that can be really, really useful. Did I pump in the car on the way to work? Yeah. And took care of newborns. And so I think that Dr. Reen really pointed out one of the larger challenges is the work that we have at home as women. And I do have hope that certainly with future generations, and I have a really supportive partner, it is that how do we share that workload? I think to help allow women in healthcare in all positions, RNs, MDs, APPs, to be able to flourish and then take on leadership roles, which is really important, I think, to have that female voice at committee, but also in the leadership positions, so that we can help shape the response to some of these major challenges around social determinants of health and injustice around race and gender inequality. So just one perspective.
Thanks. Yeah, and I think, you know, I'll say that many, if not most of my mentors over the years have actually been male. I think but ones who appreciate and showed me respect and valued me, and wanted to raise women up. And so I think ultimately, you know, this idea of mentorship and leading by example is so important. And so I would encourage anybody who's, well, really everybody at every level of their career, to find mentors. I think that's one of the best things that you can do, people to help guide you, somebody you can go to if you feel you've experienced discrimination or something and are not sure where to go. Just having a mentor that you feel comfortable with and who guides you in the right way is just so important. I think we're at 7:59 or 8:59 your time, so I don't know if we should probably stop.
Thank you so much, Melinda.
Yeah, thanks for having me.
Thank you.
Sorry again, it was not the, you know, most uplifting topic, but I think it's part of the whole year of uncovering problems, and then we can all make Thanksgiving a time where we give thanks for what we have and the progress we've made, and make our New Year's resolutions ones where we do address equity for everybody.
Thank you. That was really well said. Thank you, Dr. Reen. We appreciate you coming, and thank you, Kara, for letting us participate in the Laura Mann lecture series, which is always so high quality. So appreciate you using Family Medicine Grand Rounds as a venue for that. Thank you so much.
Yes,
All right.
wonderful.
Thanks, everyone. Have a great rest of your day.
Thank you. Happy
Thanksgiving.
Thanksgiving.
Bye.